have the Bluetooth keyboard. Do you want to try figuring it out? I couldn't. You want to try? I don't know.
You said you didn't want mine.
No.
You're amped up? All right, cool. All right, guys, so we're going to get started as soon as the computer gets set up. I'm very excited that you're all here, and I'd like to thank you all for coming, and I'd also like to thank our speaker for tonight. Our speaker is Professor Cho, and she is the manager for speech and audiology at LA Children's Hospital. Sorry, my words are totally not working tonight. And she has set it up so that there are various opportunities for you to ask questions and probe what it is that she does and how you can better treat or kind of pull from all of the theory that you've learned into actual clinical practice. So keep those burning questions alive in your mind so that you can ask her when she gives you the chance.
Thank you. So while we load this up, I just wanted to, am I being recorded? I'm so nervous. I actually got really nervous because Dr. Strucker said she was pending. So let's lower your expectations for my talk, and then you'll feel like I did a great job. So one thing I want to say is I'm Christine Cho. Thank you for the nice introduction. I teach, I see a lot of familiar faces, so I have regularly been teaching CD 442 speech science, so I think I recognize many of them there, and I did supervise one of the general clinics one semester, so I did do that role there. And I've been teaching the same class probably for about 5 years, so it's crazy how time flies. And then in my regular day job, my full-time job is managing the department at Children's Hospital. And there we have both speech pathology and audiology, two departments that I oversee. Prior to that, I just wanted to tell you guys a little bit about myself. Most of my clinical work was done for 10 years at a hospital in LA called Wright Memorial Medical Center. And that's a combined adult and pediatric, we have a pediatric floor, but it's an adult hospital. So most of my clinical work has been on the inpatient side of medical speech pathology, with doing some of the outpatient work in the outpatient setting with children, in that area with so I think today when Sean asked me to speak, basically we were going to talk about what it's like to be a speech pathologist in a medical setting, and if I could give some insight to the different work areas and particularly focus on an inpatient medical setting, medical setting, pediatrics, because I do think there might be some other opportunities to hear from other speakers with SLPs working with adults in the medical setting. So that was one thing I'm going to focus on. The other thing is I am very informal, and I did not realize that I feel like I've been a little bit more formal in my presentation. So feel free to stop and ask questions, and also don't feel bad if I ask you to wait, if I'm going to wait to answer the question because I'm getting to the point there. And so, see if we can get on. I think I just wanted to get a feel. I think Sean kind of told me I think we have a mix of undergraduate students and graduate students. How many graduate students do we have? Oh, yes, a few. And then the rest are undergrad. So I'm going to try to tailor some of things I talk about in with respect to, I think what's really nice about NSSLHA is that it's trying to create a space for you guys as undergrads to know sort of what to expect, what is like the long-term like future path of things that I can be doing to and learn more and get that foundational things. And if you're a graduate student, I think you're still really trying to put some of the application piece of what you're learning and what to expect. Now it's getting closer to being out in the real world, which can be scary. I don't know. Yeah. Okay, I can get started while you get it might take someone. So let me just get started. The way I had it broken down is I first wanted to talk about the various work settings in the medical setting. Okay, so I like to think of it as in 3 different areas, which is the acute inpatient area, the acute rehabilitation unit area, if your facility has that, and then the outpatient setting. And this is all within the medical setting itself. And so if we're talking about just as like in a hospital, the acute inpatient side would be those units and floors where patients are admitted for a variety of illnesses or situations. So maybe they were there for a stroke, maybe it's a child who had a traumatic brain injury, and is there, maybe it was a motor vehicle accident that resulted in a bunch of trauma or brain injury, etc. Right? You could also see a lot of patients who might be there for other reasons, but still ultimately end up needing the speech therapy service. So for example, a patient might be admitted for, like pneumonia or a respiratory condition, and it originally didn't have anything to do with speech, but because of their weakness or debilitation and things like that, they end up requiring maybe your service for swallowing evaluation, right? Or maybe it's for voicing, or they end up getting intubated, and so now they might be ready to have a speaking valve, and that might be my role as an inpatient student. So just wanted to give you guys context for what that looks like in the acute setting. We're making progress. Okay. Alrighty. So within inpatient, I was talking about right now, I'm talking about acute inpatient, right? And in certain hospitals, you might have an inpatient rehabilitation unit. And so when we say inpatient, that means you're there, you get 24-hour around-the-clock medical attention by nurses and doctors. And in both of these situations in inpatient, that would be the case. There are different reasons why you're there. So, and we'll get into that later. And then there's an outpatient setting, medical setting, which is very much like clinic-based. So in the same way that you have a private practice or even our clinics here for providing therapy, It's the same type of framework, but just provided connected through a hospital or medical center. What I didn't write here is that there are other facilities like subacute settings that aren't actually hospitals, as well as nursing homes and long-term care facilities. I personally haven't worked in those, so I didn't want to, I forgot to include those, but those are all still considered medical setting for an available procedure. Okay. One of the things I wanted to say in terms of outpatient is it's a clinic-based, right? Meaning you come from home and you're doing therapy in the department's therapy room or, a clinic, right? And then there's also within a hospital, oftentimes specialty multidisciplinary clinics. And so, for example, and we'll get into that later, but as an SLP, I might have a role to play as part of the team and in those. So, sorry, kind of backtracking a little bit, but there are many units and floors, and it's typically based on, and I'm going to just speak first about hospitals, but usually are categorized based on your type of illness or the severity or acuity of your illness. And so, for example, if you're in the ICU, that's probably the highest acuity, meaning you might be the most critically ill. And so that's why you're admitted to that floor, right? So you can see patients as an SLP in any of the floors that are there, because depending on the need or where the patient is, just means that you might adjust the type of therapy and intervention or plan that you create for those patients based on what they're able to do and also what their level of impairment might be. So some examples would be, for example, and not all hospitals have the same types of floors, but they kind of typically have general themes that are very common. So an ICU or an intensive care unit, for those of you who don't know what ICU stands for, there might be a neurology floor, so maybe all patients with either like neurological disease or an event like a stroke, maybe it's something that's another type of neurogenic disease, maybe you might be admitted to that kind of floor. Med-surg is for more stable types of patients that are there. Sometimes it could be surgical, things like that. Often there's an ortho floor, so if you had a hip replacement or a knee replacement, those are the kinds of post-surgical kinds of floors that are very specific to those types of procedures. Anyways, I can go on and on. I did want to talk about in a peds setting, it's very similar, right? So there are going to be intensive care units, but they're categorized a little bit differently. So, for example, there might be a cardiothoracic ICU, so all the cardiac condition or surgical procedures or things like that involving a cardiac issue. Oftentimes they will separate that because it's just more focused and centralized to be able to have care there. NICU is the neonatology intensive care unit. BMT, and this is, I'm speaking now for Children's Hospital, the bone marrow transplant unit. And so we have quite a large bone marrow transplant unit for those kids going through cancer and treatment and things like that. And also I just put look because there's other examples. So what's really interesting is, as an SLP in the inpatient side of things, you're really treating patients at the bedside, and they're really in their most vulnerable and ill state, right? So I think one thing that you learn probably as a student when you're placed at an externship that probably comes as a surprise is what comes with that. It's not just about knowing how to do speech therapy, but learning how to relate to families and caregivers and patients as they're going through these kinds of things. So you could be the best, most knowledgeable speech therapist, but if you have bad bedside manner or you don't really know how to relate to people and read the room and adjust to sort of where they're at, that's a really, really important part of being a good coach. I would say that in your student externship, I think once you're in grad school and even if you're doing therapy in our clinics, right, you have to be able to communicate effectively with parents. Sometimes there might be concerns that you have that a parent's not ready to hear, or a caregiver is not ready to hear. Maybe it's their educational level or their cultural background that creates a difference in the way that you need to adjust to how you talk to them, right? So a lot of us we're all, we kind of think about us. So well, I'm saying the right thing. They need to hear this. I feel like this is important, right? I think so much of the art of therapy is learning that skill of how to really adjust that, because no matter how smart you are, or no matter how much you think they need to hear that, if you're not at their level, all of that can get lost, right? What did I get on that? Oh, right. So the other thing I was going to say about being in an acute SLP in an inpatient setting is you kind of have to get okay with being comfortable with lots of ventilators and tubes and IVs, and that can be really overwhelming. What I would say is, I would not discourage you if you're like, oh, I couldn't do that. That seems so intimidating. I never thought I would be in a hospital either. And it's something that you learn and you kind of get adjusted to. And that's also in and of itself something that's part of the learning process. I would say don't let it intimidate you. That's why you have to learn. At the same time, if you're someone that, like they decide to, like vomit, like maybe the ICU is like not a great place for you, So just kind of knowing what where you're at and sort of what's interesting to you, but also being open to what's out there, knowing that it's a process. Okay, so in an acute inpatient setting, right? Patients are admitted, they're there 24 hours a day, they're sleeping there, they're getting their
Hi, Lena.
and so therapists
How are you?
bedside on their
Did you come back from karate?
Yeah, I just got my new belt. I'm going to all
Is
the
that like
different
the
grades,
top
right?
belt?
They're not coming to me.
not
I'm gonna
almost
go and figure out, okay, Bobby,
but like
Bobby Smith
it's
is in,
yellow
you know,
and it's like
blah,
the
and
higher
you
level.
kind of
That's
make
so
my schedule
cool.
and-
Are you excited for
and
Halloween
and
tomorrow?
Based on your
Yeah.
workplace, it
I
might
think I'm
already
just gonna be a black
organized where,
kitty.
like, there's like a primary person.
Yeah, what about you?
When you're a
Nice.
or whatever, so
Uh-huh.
Mommy's gonna be Black
is,
Widow because she
you
has
know, you
black
always have
clothes.
to adjust
and
also
she's
your job
gonna-
and what-
She has like
okay,
Nerf
and
guns.
so
Uh-huh.
the main thing I want to talk about
Like,
was the difference in how you adjust your therapy. How does therapy look different based on what different work area you're in? And so when you're in the acute inpatient setting, this SLPs you're focusing, your therapy goals are basically focusing on short-term goals, because they're not gonna be there for that long, okay? And really the goal is to function is focusing on their safety in the hospital and their function in the hospital, in this hospital setting. You're not necessarily focusing at this moment in time. They just had a stroke 3 days ago. You're not focusing on, okay, well, what does your house look like? Like, what are you doing at home, right? You might if they're high level and maybe it's not a severe case, but I would say for the most part, the goals for inpatient acute care is typically therapy, even for physical therapy, right? Any kind of therapy is what can we do to help you be safe here? What can we do to help you communicate your needs here? I'm a speech therapist. You can't talk. Okay, well, how are we going to make you be able to communicate the best you can to your nurses, to your family, to your doctor, if that's right? So I would say that's a big adjustment. And so for me, in my practice, I had a split caseload where I would go to inpatient and sometimes go to outpatient with peds. So in the same day, I might see somebody who just had a stroke 2 days ago and be working on some really basic receptive comprehension, expression kind of things. And then later on in the afternoon, I'm going to an outpatient where it's a kid coming and goes to school every day, is really functional, and I'm working on cleft palate speech. So really kind of be able to adjust to the work area and of course each patient. What are the typical types of patients in an acute inpatient? I think we kind of talked a little bit about that. I wanted to say, I think in the inpatient side of things, acute side of things, I would say that there's a pretty heavy proportion of swallowing and dysphagia therapy, I would say. I think in that critical time, there tends to be a lot of eating and swallowing issues, and that's a primary concern because you got to stay nourished, you got to stay hydrated, you have to be able to swallow safely and not get more sick based on what your ability to swallow is like, right? The other thing I would say is like, so then for me, we were a certified stroke center, so along with that came a lot of speech and language, so understanding, comprehension, right, receptive language, expression, and speech. And then I would say the other thing too, like, so for currently in, I would say traumatic brain injury in whatever shape or form. So it could be acquired from an accident. And I would say that would be another kind of high volume of things. The other thing I wanted to say about that is I think cognitive communication is often an area that a lot of people, including medical providers, don't necessarily focus on or may not see right away, right? So your ability to problem solve or pay attention or remember things may not be at the top of the list when physicians are trying to make sure you're stable medically, right? That makes sense. So I think part of it is also understanding. To me, I'm a speech therapist, like, why don't you care about, like, don't you care about their cognition, right? And so again, a lot of it is also having the right relationships and expectations and communication within the medical provider team to be able to collaborate in a professional way and understand when that might not be the focus right now for this patient. So I can be doing that in my therapy and knowing when the right time is to have that be more of a focus for everybody else. Make sense? At the same time, I would say there's a lot of advocacy, I think, that we need to always continually do. And I would say in a lot of my mentoring, that is in my own experience, I've felt this too, is sometimes it can feel frustrating because it's like, I mean, how many more times do I have to explain to this doctor that, you know, speech therapists also do therapy for cognitive communication, right? Or cognitive linguistic skills, depending on what the terminology is. That makes sense. And so I would say for me, I have found the balance of the patience of like accepting the reality that depending on where you're at, like for example, all the hospitals I've been to have been teaching hospitals. So there's new residents every year. It's just comes with the territory, you know, just every year you're going to have a new batch of physicians that are new and need to be educated in a way that's professional and welcoming and not condescending, like, how come you didn't know that, you're a doctor? Or why is that not important to you? And sometimes you feel like that, like, oh my gosh, I'm like repeating myself over and over, but I really kind of feel like that's part of what this advocacy in our own profession is educating others about what we do and not getting too impatient and feeling frustrated by that. I mean, sometimes you're gonna feel frustrated, right? And I think depending on the team you have, I think like, you know, there definitely have been lots of physicians who might have been a little bit, you know, hesitant or reticent to entering speech therapy consult, you know, for patients. And over time, like understanding, like with having more conversations about why it would be helpful or why it would be important, you know, have really come back. So that is my elaboration on that. I would say I wanted to just talk about one thing that I think is pretty atypical or more typical in the acute, in a medical setting, is working more with speaking valves and trachs. So through grad school, I think I didn't really learn that much. You know, there's such a wealth of knowledge in our field, and it's impossible to learn every single thing. So I like to think of our profession as, first of all, I forgot I should open with this. I always say to people, you know, I feel really blessed and lucky to have a career that I really love. And I think a lot of people can't say that, right? Most people want to learn more for their job. And of course, with every job, there's going to be things that are frustrating or annoying. Like, I don't want to do that thing or whatever. I'm not saying I have a dream job every day. But at the end of the day, I feel like we're so lucky. It's such a great field because you just have so much meaning to it. It's challenging every day. You have opportunities to learn new skills every day. And there's such a variety of different specialties or focuses of area that you can go into that I really think that is one of the beauties of our field. It's also one of the challenges as a new clinician because there's just so much to learn that you couldn't have possibly learned or had experience going through grad school. So that can feel scary, right? It's also why our field has a clinical fellowship period of time where you're required to have supervision once you're in any job, right? I like to think of it as our residency kind of equivalent, where doctors got to have, I hope somebody's like watching them the first year, right? And so what was my point? The point was I love my field. I love my career. And the point is that I never really learned anything really, not very much that I could remember anyway, about like tracheostomies and ventilators, okay? Because that's really practical, hands-on, very specific. And so, yes, I learned about the anatomy. Yes, I learned about those things, but I never really connected the dots of like, what's a patient, like, what am I gonna do with a patient on a ventilator, right? That's very scary to me. And so a lot of, I think, what our skills are that we continue to fine tune and hone our skills and really truly actually even learn certain skills for the first time on the job, on the job training. And I was lucky to have really great mentors at my job. And so, I learned all about it once I was there. Once you're there, by the way, another common question I get is I think people feel scared that like I'm gonna show up the first day and I'm just gonna have to see patients, and how could I ever do that? I mean, I hope they don't let you see patients right away on the first day. Most places have some type of competency training sort of structure, right? So even if you've been a therapist for, let's say, 10 years, at our hospital, on certain skill sets that are considered more complex or could be potentially, risky, let's say, we still have like a competency system where everyone you get validated and checked out that you kind of know what you're doing. And if you're very new, then maybe that looks like longer and more mentoring. And if you're very experienced, maybe that's shorter, but you check yourself. Does that make sense? So I feel like that's very comforting for people to know too, that they're not just gonna have you just go try it out, it's a person's life, and want to keep people safe and get you the good training. Okay, so I do think that we see a lot more speaking valves. So that's, there's many different brands. One of the more famous and more widely used is called Passivor. And those are patients who have a tracheostomy and cannot voice because the tracheostomy is, taking my class, below the level of the vocal folds. So the air is coming in and out below the level of vocal folds. And so air is not able to pass above and vibrate the vocal folds to produce your voice, right? And so there's this one-way speaking valve that is placed as speech therapists that will assess to see if you're ready to be able to use that valve. It lets air in more readily, but it blocks the air coming out and forces the air up through the mouth. And you have to work with the respiratory therapist to make sure they, deflate a cuff, a balloon thing, if there's a balloon thing, okay, that you'll learn about. And so that's, I think, pretty medically involved. What I would say is, for me now, so remember I worked for a long time as doing I was the actual clinician. Now I'm doing more management at Children's Hospital. We actually see quite a bit of speaking valves in children, both on the inpatient and outpatient side. And so that's like the theme of medical setting to me, is you just tend to see population of patients who have more medically involved kinds of things. So even on an outpatient level, if they're coming for their 1-hour appointment once a week from home, you might have something that the patient, for example, who has like a craniofacial syndrome or cleft palate syndrome, where they're for voice or they're here for Passivor valve, depending on what type of how big the place is. So for us at Children's Hospital, we actually we turn away general articulation in the absence of some type of medical condition, because our wait lists and our providers we just get so many referrals that we feel like people and providers in the community can provide that service probably better than us, and that we want to be able to see the patients that maybe there aren't as many options for patients to be seen. So we do kind of refer out. At the last place I worked at, we also took early intervention children that wasn't medically necessarily have medical conditions. So it just kind of depends on where you work. So just FYI. I just wrote that there because I felt like that was something that's more you see more in medical setting. The other thing for speech, for example, currently at Children's Hospital in our outpatient setting, which we'll talk about, I would say we have probably like half of the caseload is craniofacial or cleft palate speech children. So they might have other things going on as well, like hearing issues or other syndromes. But you might also have a child who just has circulate only, and that articulation therapy looks really different than a standard or maybe a general articulation like a lateral wrist or an R issue, right? You might still be working on S, but it's because you're working on high pressure airflow and not working on nasality, whereas another child who's working on S might be because it's a frontal wrist, like that, right? So you're going to treat it differently. You can't use the same approach for even though they're both S goals. Make sense? Okay. And then one thing I want to highlight about the most effective communication modality means maybe someone had a stroke, can't speak, can't fully understand, they have impairments in receptive and expressive language. And in that moment, it's not realistic in the timing to think that they might regain their ability to express themselves. So then you got to think about, okay, well, if you're just so narrow-minded to think I'm going to get them to use their words, that's not necessarily realistic either, right? Got to meet people where they're at in their levels. And so maybe it looks like just determining and finding the best way that they can at least do some communication, right? So maybe it's a very simple picture board of only, you know, yes and no with a smiley face and a sad face because they may not be able to read, right? And so then we're going to train and educate family, nurses, doctors to only ask yes or no questions. How are you doing? Are you doing good? I can answer that yes. Okay. Do you need anything? I can answer that yes, right? If you don't ask, you can make a lot of assumptions based on just yes or no, right? And then it's like, are you a man? Oh, all of a sudden it's like, oh no, wait, this is inaccurate. That's an actual example of maybe how I might assess somebody's comprehension. So that's hard actually to start to teach somebody to only ask yes or no questions. But guess what? If you're pretty accurate, let's say I determine that you're accurate in doing yeses and nos at least, but you just can't adequately express yourself. Maybe that's the best, most effective way for them to communicate, and at least they could express and communicate what they need, right? Do you have any pain? At least you know that. Are you thirsty? You know, you can at least get some basic needs met, and that might be what your therapy is about. In another situation, maybe it's a trach patient who is not ready to do a speaking valve. You've already done that. You've already tried that. Or maybe respiratory therapy has said, hey, they're really not ready to try that level of their own respiration. Okay. And so that's not an option. Well, what happens? You can't talk, you can't hear them talk, but let's say we've already assessed them and they can understand. That really stinks, right? How frustrating is that? You can't really communicate. So that might be educating the nurses station so that, you know, with the nurses, like, so this is a true story all the time, actually, just that. Patient calls the nurse, and the unit station is usually the nurse. There's somebody who's there who will answer the calls. Yes, Mrs. Smith, do you need any help? Hello, do you need any help? Okay, okay, let me know if you need anything. And they hang up, right? So she was innocent. She's doing her best. She answered the call. She did what she's supposed to do. She double checked, right? But if that person can't talk, or you can't hear them talk, maybe part of your role is establishing the most effective communication method for them. So is that having them like tap on it, having a sign at the station that's handed off to every single shift of nursing, right? It's talking to the nurse in need, making sure they always know that. You know what I'm saying? So some of that is it posting signs at the bedside, you know, patient can understand, ask a certain question. That might be part of what your therapy looks like. So I think that's a big thing where we sometimes don't, that's what I mean by adjusting your level or your goals of your therapy, because it might not just be, oh, I'm going to just teach you how to talk, you know, or I'm going to get you to be able to express yourself. So that's one thing I wanted to say in terms of most effective communication. Maybe they can write. So you always have you have a very, involved communication board, and there's tools out there and resources that places will have. And then we're still on acute inpatient, so a lot of swallowing. That might mean trialing different textures and foods to see if they're safe. It might be referring them or actually doing an instrumental study like a video fluoroscopy to see what their swallow function is like. And then based on how you assess them, implementing different exercises that might help strengthen your swollen muscles, techniques or compensatory strategies that might keep them more safe. And I have a story about Dr. Veal, actually. A good story. It's like burned in my home. And then make an appropriate plan, right? Sometimes you're the one that is finding out and assessing that the patient's not going to really be able to safely eat by mouth, and that's tough. You're making that recommendation to the doctor to consider doing a non-oral means of feeding, right? Whether that's a G-tube, maybe it's an NG tube temporarily, things like that. So you want to hear my story about Dr. Veal? Yeah. So Dr. Veal, to me, it was probably one of the people that I really enjoyed listening to. I actually listened to my professors because he does a lot. He's an incredible clinician and also professor. And so he gave so many good real life examples. And I just really remember that. But the thing that really brings in my memory of Dr. Veal, and I literally repeat the story to every student I mentor and every CF I mentor, is there was a time we were talking like way later, and it's a long story, but the reason why we were on the phone and something's kind of happened, it's like, oh, remind me again, you know, where are you at again? Like, when did you graduate? How far are you out of school? I was very proud of myself at this point. And this was when I was 3 years out. I said, oh, just about 3 years. I'm just about to be 3 years out. It's like, oh, that's great. You know, that's great. Okay. And he, you know, Dr. Veal, you know, right? He's like, oh, good. So you just feel like you know what you're doing. Right? You know, you're just starting to feel comfortable with how are you. At this point, by the way, I'm feeling really good about myself in my clinical life, thinking I know a lot and a lot more than I probably, you know, I felt way too confident probably. And that's why it's burned in my memory, because that day, it was like such a humbling experience for me, because at first I'm like, well, I mean, not like just know what I'm doing, right? And then when I started reflecting on it, I'm like, it's actually really true, right? I'm not saying I'm a bad clinician. You don't be like so tough on yourself and insecure about your skills. You should have confidence. But it's that idea that you never stop learning. And the minute you start thinking you're such an expert at something, you're just missing a huge opportunity to learn. And that was very humbling for me. And so now I don't say that to people. But I say the same thing about kind of, it doesn't really matter where you're at. You know, you could be 10 years out, you could be 20 years out. If you're not open to learning, and sort of, that's to me was a take-home message. And so it took me down a notch and made me be a little bit more humble, because, and the reason I say this, I can share with you, I think I was probably overconfident at that time. And so I was not as receptive to getting feedback. So if somebody said, hey, why did you do that? Yeah, sure, I could be professional, but inside I was like, well, I mean, you're not that great of a therapist either. You know? Whatever it is, you know what I'm saying? And I think that's really important. So I've mentored a lot of students and a lot of CFs along the way. And I would say, truthfully, you know, you feel like, okay, the first year you're like, oh, I don't know anything. Then you're like, okay, I got through my year. And then now in your second year, you're independent. And you're like, okay, well, I know what I'm doing. And so people start to give you some feedback, and maybe it's someone that you don't agree with their style. So now you're like, well, thanks, but okay, yeah, sure, right? But there's so much you have to learn. So I always tell people, I don't care if you really dislike somebody's therapy style and you don't actually think it's effective. There's always something that you could learn from, that you could take from, and you don't have to adopt their style. There's always something to learn from. Anyway, I will never forget that. The other humbling experience, I went to a video fluoroscopy conference. At this point, I thought I was doing pretty good. I was 1.5 years out. They gave us a pre-test. We flashed it up there, and I could only answer 5 out of the 10 anatomical thingies, right? They won. And I will never forget them. Like, oh my gosh. And so from that point forward, you know, like, just always remembering you have stuff to learn. You shouldn't, the minute you start getting too complacent with where you are, there's more articles, there's more research out there. That's my soapbox. Okay. Alrighty, so moving on to the inpatient rehab unit. Basically, if your facility has this, it's still the inpatient side. Patients are still there, but the reason is different. So now you're a little bit more medically stable, but you're not quite strong enough to go home. So the purpose is for therapy and rehabilitation. And so you have to be eligible to meet certain criteria to be admitted to this type of unit. And one of the main things is, among others, is the ability to participate in 3 hours of combined therapy. So physical therapy, occupational therapy, speech therapy. So altogether 3 hours a day. And so if you're really, really debilitated and so weak that you couldn't do that, then you wouldn't maybe meet the criteria to go. If you, right, and the focus is on improving strength and functional skills before discharging home. So now, right, my goals are looking a little bit different. So on the acute inpatient side, I'm like, are you safe here? Can you kind of communicate here? Are you effective here? Very short term. In the inpatient unit, you're typically admitted for about 2 to 3 weeks, and you're getting 3 hours of therapy a day, 5 to 6 days a week. Okay, so some places do 5, some places do 6. And so now the goal is for me is to have you increase your independence and your function, right? Can you or you're going to go back to school, let's say, right? You're a child. Can you pay attention long enough? Can you speak clearly enough? Can you problem solve enough to be able to attend a regular school? Do you need an IEP, things like that? In our rehab unit, we get a very high volume of traumatic and acquired brain injury patients. And so in pediatrics for us, it's, pediatrics means for us is 0 to 21. And so we see a lot of patients. So we have teenagers who were, some examples might be in a car accident. You might have a sports injury. You might have a 3-year-old where a television fell on their head. That's a traumatic brain injury, true story. It's actually alarming how many TVs fall on children's heads. And so things like that. And then cancer, so maybe a blastoma, medullary blastoma is very common, brain tumor, things like that get resected and treated. And so now it might have affected some impaired part of your brain, and that part of your brain might be involved in executive functioning, reasoning, right, paying attention. And you need all that. That's all in the domain of what we do as speech therapists. In the adult side of things, maybe you had a stroke. Actually, you have children too who have strokes. So if you had a stroke and you are needing to communicate your needs, right? Like, can you order from a menu? Can you, even things like the basic things that you think are so easy, right? You look up movie times on the internet to find out what time you're going to go to a movie, things like that. Part of it. What's pretty cool about rehab unit is that a lot of times you're incorporating sort of functional independence kinds of activities or exercises. So one thing we do is something called a community outing. And so that's together with like maybe a physical therapist and a speech therapist might take this patient, and we have like a Vaughn's next door that's a block away. So the goal is community outing to see if we can put these skills into place and practice them in a real life situation. So the physical therapist might be working on, right, their ambulation or walking, their balance while they're going, their safety with their walker, or doing that. And then the speech therapist might go there and might say, okay, well, we're gonna bake a cake for your mom or something like that. So you have to find the cake mix and these ingredients, and here's $10, and you have to manage to get the right change. These are all like cognitive processes, so I think that's pretty cool. Sometimes they'll go as far as taking the metro to Hollywood, and where is that place called? Hollywood Highland, that you can do something fun. So could you read the map of the metro? Oh, obviously there's like enough security and things like that to go. But so that's pretty cool. And the adult side of things, it might look like a home visit where you are going to their house and sort of mimicking some of those activities we might do. Many units have like simulated rooms, so like an actual bedroom. So practicing getting dressed with the OT, right? Transferring in and out of the bed. I know, I think it's at Rancho Los Amigos, and they have driving simulation. So a lot of OTs will, occupational therapists will do a driving simulator for driving. So pretty cool. Here, the SLP might see the patient at their bedside in their room, or usually rehab units will have some type of like a therapy room or a gym or something. So you might, because the whole goal is to get them up and moving and doing as much as they can. So you might go to one of those rooms, and other times see them in the room. Okay, so focusing on functional skills, get ready to be back at home in the community. So that's a big buzzword in rehab, is community integration, getting back in the community. And I think we already talked about that. So basically, those are the types of patients we might see in the therapy. Outpatient. So I say quote unquote clinic based because not all medical settings necessarily have a clinic, but it's that type of principle, right? That patients come from home to their appointments in the clinic. It might be 1 to 3 times a week. It could be once a week. It could be twice a week. It could be a 30-minute session. It could be a 60-minute session, depending on what their goals or their impairments are. And so they come to you. So if I'm an outpatient therapist, I have my day set, and I have Bobby at 1 o'clock every Thursday, and Sally at 2 o'clock every Thursday, etc. And in these types of situations in the medical setting, it'll typically be clinic-based, where there's therapy rooms, and so you're going to whichever room that you're in, and there's different types of, very much like clinic here, right? Lots of resources, materials, therapy materials, games, things like that to work on. In an adult setting, same idea. It's just not going to be a small little table, right, and small chairs. But maybe you might have an iPad or a computer where you're doing some type of integrating some of these skills or activities that way, or not. And actually, in our facility now, we have iPads and things like that too. Focuses on improving their existing skills and to increase the independence at home. So this is like more long-term, right? So this is now where I might start focusing really a lot more on reading and writing, let's say, for an adult stroke patient, that maybe on the inpatient side, when they first were in the acute side, I'm not really working on reading and writing. I'm really working on, can you safely and functionally be able to communicate and speak and understand here? I'm not necessarily, even though you can't read and write, I might not choose that to be my area of focus to work on as a goal. Whereas now, maybe 6 months later, 4 months later, they're in outpatient therapy. Now they've regained some of their function, and now that might be something that we would consider. Again, you might get different severity levels of impairment. So you can still have an acute inpatient patient that is pretty high level. So you could start, I'm not saying you couldn't do reading and writing there. You're always adjusting based on sort of what their skills. I wanted to talk a little bit about specialty multidisciplinary clinics, because I think that's pretty neat if you're in a hospital setting. These are things like craniofacial clinic, pulmonary clinic, GI or gastrointestinal enterology clinic, ENT, ear, nose, and throat doctor, or otolaryngology voice clinic. So these are within the hospital, but set up so that it's a multi-specialty kind of center, right? So you have multiple people on the team. So if it's like the pulmonary clinic, you have pulmonologists, you have nurses, you might have the respiratory therapist there, you have a feeding or swallowing therapist, an SLP or an OT, depending on where you practice, all there. And you're all providing care for that visit. It's like a follow-up or an evaluation based on each patient, obviously, right? And so you might see multiple providers that day, and as a speech therapist, I might be one of those providers. So for us currently, our biggest clinic of our participation is craniofacial clinic. So in that day, they really are seeing, sometimes up to 7 providers. It could be a dentist, the nurse case manager, the dietitian, the social worker, the plastic surgeon, the speech therapist. I mean, you could see the audiologist. And they usually typically come once a year for continued follow-up to make sure that they're getting all the care that they need. So in specialty meaning, they have that special need. So pulmonology clinic is likely because the patient has some type of pulmonary disease or condition that requires that level of like follow-up over time. So that's pretty cool. What's neat about that is your role is to provide your own care, but then communicate and collaborate with everybody else. So oftentimes these will end in a team conference, and where you're discussing every patient, kind of talking about what their needs are for speech, making sure the physician and nurses are aware so that they can, and like the nurse case manager, so they can follow up on that. So I'm not going to see them again for another year, right? Or maybe I won't see them for another 6 months. So kind of relaying all that information. Our audiologists play a really big role also in our craniofacial clinic. Some craniofacial clinics don't have immediate testing on site. Sometimes they set them up for a different day. For us, we are able to incorporate it. So that's pretty integral as well. So letting them know, hey, they need to come back for hearing aids. You need to make sure like they're fit at school and they're getting the right kind of support, that kind of stuff. So I would say you get a lot of good practice in talking with lots of different types of providers and personalities, and you got to be professional, but you have to also be able to, again, like relate to other people so that in a respectful and collaborative way, even when you don't always agree necessarily. And I was, again, the typical types of patients in outpatient, I would say in a medical setting, tend to be more heavy on some type of medical condition, right? So they're there for PMD, they're there for voice, they're there for craniofacial. You might have a patient who is post-stroke, things like that. However, I would say there are definitely lots of medical settings that also provide the whole entire spectrum, and they don't necessarily triage or report out for anything, they'll just accept every type. So I don't want to mislead you either that if you worked in a medical setting, you'd never get like maybe a general Arctic patient. That definitely. I think that's it of the overview. Is that okay? What kinds of kinds of questions do you have? Yes. Did you always know? No. The question was, did you always know? I didn't. In fact, I thought I was going to be, I was very sure I was going to be a SLP in the school district. And I was very sure till my 2.5 year in grad school. And what changed it, did I hear that? Yeah. What changed it is that I did my externship in a hospital, and I just had never been exposed to it. Truthfully, I think I'd only ever been in a hospital at that point in my life once. I guess I didn't have as many experiences with sick family members or friends. And so I don't think I really knew, I also definitely didn't think I wanted to do therapy with adults. I thought for sure I was 100% peds all the way. And I think that was one thing that changed for me, was being in that and being really surprised that I really loved it so much. For me, I mean, I'm the speech science professor. I do tend to be a little bit more science oriented. I like science. I don't think you have to love science to be in the medical setting, but it was, I think that is something that surprised me, but it didn't surprise me because my bachelor's is also in linguistics. And before I turned to linguistics, I was actually a biochemistry major. I stopped that, but way too late. I ended up using organic chemistry as like my GE science credit. So the point is, it kind of fit for me, but it wasn't something that I expected at all. Right? And then on the other hand, I had a friend who went through our program, and I graduated from CSUN, just to be very simple. And she knew. She's like, I do not want to do hospitals ever. Even the smell of the hospital makes me sick, and that's just not my passion. I just know that I don't want to do that. And so she requested to have her adult placement not be a hospital. So she ended up doing private practice with adults. And she got a great experience doing that. So what I say to people is, I hear two things. I know for sure I want to be a medical speech pathologist in a hospital. You might know for sure, but there's a good chance. I just always say to people, like, be open, because what you don't know until you're out there experiencing things. So that's my other advice. Any opportunity you have, which is very difficult, I know, to have any exposure or observations to different types of work settings, it is great. I know lots of coworkers and colleagues and friends that maybe started in the hospital and then ended up moving to the schools and love it. So I think the other misnomer, or I think misconception, is sometimes people, I think you can be a very high level speech pathologist. Yes, there are challenging things in a medical setting, but there are also equally or more challenging things that come up in the school district or private practice that SLPs there can treat patients better than I can. And I say that because in an outpatient practice, you don't know what's coming in your door, right? For me, I kind of see the same wheelhouse. Yes, it's different, it's challenging, different levels. Of course, I'm always challenged. But one thing is I did outpatient for a little bit, and you don't really know what's gonna come in your door. So you have to I had to know about a little bit about voice. And if I didn't know about that, I had to be able to advocate to learn more about voice. I need to refer out to say, hey, I'm not a specialist in voice. I told my manager, I don't feel comfortable. I don't think it's right for this patient. We should refer him out. And in other ways, you know, to teach patients maybe who came with like Parkinson's or cleft palate, or you don't know what's going to come in, right? So that's actually, I would say, very, very challenging and equally, I think, stimulating. So I would say that's sometimes a lot of misconception types of comments I hear, that maybe being a school speech pathologist is easy, and it definitely isn't, right? And the other thing I was going to say is, who sees these school age kids the most? A school speech pathologist is seeing a huge multitude and variety of patients, students, right? And guess what? That kid that's coming to me for extra speech therapy, for cleft palate speech, that's extra because they need that special attention and maybe more specialized treatment. But at school, they're getting speech therapy at school too. So as a school speech pathologist, I hope you are trying to be open and learn about different techniques on how to do cleft palate speech. Because if you're applying the same knowledge to your other S kid, that's not great, right? So there's so many times that as a medical speech pathologist, I'm collaborating and communicating with the school speech pathologist to ask, hey, do you think you could adjust the goals a little bit? This is what we're thinking would be helpful. If we're all doing the same thing, this is why. And you're kind of having that professional collaboration. But my point being, you're going to get a variety of different areas on the spectrum of different types of patients, no matter what setting. Yeah.
I know you mentioned swallowing. How about feeding?
Yes. So feeding and swallowing. Okay. So in the adult world, we don't call it feeding. Typically, it's swallowing and dysphagia therapy. And then in pediatrics, we start calling it feeding and swallowing. Right. Not to say that there isn't feeding involved in adult swallowing, because there is, but it's a little bit different because children are children and babies are babies. Yeah, that's a huge practice in SLP. I think it's also one in our profession that is often, how am I going to say this? We overlap in our scope of practice with occupational therapy. And so what's interesting, I think, is what I tend to notice, and others can chime in, is based on the region of the US, you kind of tend to find that OTs see more feeding and swallowing in certain states or regions in the US. And then in others, usually it's SLPs. So for example, on the East Coast, I would say in the pediatric medical setting, typically SLPs, and in the Midwest and the East Coast, it's all SLPs. And OTs have a hard time getting into like a NICU or PICU to do feeding and swallowing. And then on the West Coast, for some reason it's reversed. And I don't know, that's not totally accurate, but that's just my own observation. But so for example, in the state of California, I would say most pediatric facilities, it's occupational therapy, and speech therapists have a hard time getting in the NICU. My current facility at Children's is we've committed to a joint dysphagia practice, so that both disciplines are treating together, so it's not just one or the other. I think Colorado Children's did the same thing, and so it's anyway. The point is that you might have a facility that has a SLP doing, but you also might have a facility where it's an OT, and maybe you're not ready to accept an SLP it is a huge practice. It's as well as in outpatient. So feeding therapy can look like not just about safety of swallowing, but it could be behavioral feeding. So there's like a huge practice of behavioral feeding. So you might have aversion. You had a G-tube for a long time when you were young, and so you kind of developed an aversion to anything oral because you weren't used to being stimulated. And so now that the G-tube is, they're trying to wean you off the G-tube, the goal is to try to do more therapy to get you to take more, to have the child take more intake. So that's a big one. Yeah, so it's definitely a huge purpose. Yeah. Yes. I mean, I don't know statistics, but I would probably venture to say yes, just because there are fewer hospitals than there are schools. So I would probably, say for the most part, I would say it's more difficult, yeah. It's easier to get a job in a skilled nursing facility than it is a hospital as well. Probably, yeah, I would say that. And I say that not in a discouraging way, that's just the reality, right? So even for placement, it's tough to get a graduate. By the way, give your clinical coordinators give them some credit. They try very hard to place all of you guys in a region where there just aren't that many hospitals. And there's lots of other universities in our area trying to also that have grad students. So yeah, so I would say it tends to be more difficult, yes. It's also timeout. It's also about opportunity. I would say there's also a level of a certain level of opportunity in networking too. So for example, you just could be at the right time, right? For example, I have no openings right now, but last 6 months ago, I had 2 randomly all of a sudden because somebody decided to leave. So, you know, it just kind of depends. Maybe in the student, like in audiology, for example, and our student ended up applying for the job because one was open, but had the student before that, there was no job opening, and she just didn't have the opportunity. You know what I'm saying? So I do think there's part of that. That's true with any job, right? Yes.
I have a question from a live streamer. Her name is Rachel, and she's tuning in from Memphis, Tennessee. She's a distance learning student.
Hi, live streaming. I'm being live streamed. Okay.
So I have a question.
Yes.
She wants to know, I'm applying to St. Jude Research Hospital for a clinical placement. The program only takes 2 students in the whole country. What is the committee looking for on my application that will stand out to the clinical placement team at this pediatric hospital?
Great question, live streamer. I cannot speak for St. Jude, right? I'm going to speak based on what I personally think, based on the 2 places I've worked at in a position of accepting students. Okay, so I can speak to that. I think there's some common themes. I think there's just the reality of it's very competitive, right? So there's a baseline buffer. So you got to be a good student. That's number 1. Okay. Now, I'm not going through resumes and saying, oh, I'm only going to pick these and you're automatically out because you had a lower GPA, right? So that's not the only thing, but you have to have a certain level of being a good student. What's hard is that every placement is a little bit different. Every placement probably has some application process, but not all of them are interview-based or application-based. It could also be based on the relationship of that site with your clinical coordinators or whatever, right? So if I'm gonna just do based on what would make you stand out as a good student, I would say being a good student, I would probably say to some degree, your experience in your clinicals, okay? Now that's out of your control sometimes on what placement, so it's not necessarily what placement you get, but maybe how you did. Most places might ask for letters of recommendation, so that tells me a lot more than just your transcript. And for me, I'm just gonna talk about me. I know our committee, when we look for graduate student placements, because we are application and interview based, we like to see that you have pediatric experience, and if you had medical or some type of observation or like something that might stand out. But again, you're a graduate student, so you might not have had that opportunity to ever go anywhere. So that's probably what I would say. Extracurriculars like volunteering, or I'm not saying you have to go volunteer at a hospital, but that would make you stand out to me if you had some type of volunteer. It's not required. We've certainly taken students who had no volunteer experience. So ask more questions about that, because I feel like I'm missing something. What do you?
I've been showing a commitment to
So in case the live streamer couldn't hear that, you know, some being attributes of being a team player, personality things. So for me on your application, that might be hard to shine through. But if you have, you're writing, you know, like a letter or a cover letter, very important cover letter, by the way, even when you apply for a job. So I'm not this hardcore, but I know certain managers that if you don't submit a cover letter, even though it wasn't required, they don't even look at your application. So if you get 100 applications, you have to find a way to weed things out, right? Because I can't go through every single one, they all start looking the same. So I would say cover letter, and then, if your student placement asks for a cover letter, that's an opportunity, like Dr. Stryker just says, to let your personality shine through. So yeah, commitment to being a team player. Other experiences too, for me, I think it's very telling if you have, you can show your team player attributes, even through things like your community work. You know, maybe you're really involved with your church, that says something, right? If you could kind of talk about that. If you have, what's your sensitivity and commitment to cultural diversity, also important. And, you know, being really open. So what I'm looking for in a student though is someone who is really open to learning. So I know I was kind of being playful earlier, but really truthfully, I would say our most negative experiences are with students and students themselves who don't do well, is when there's some type of conflict or clash about feedback and a willingness to learn, right? It's not great. It's not a great experience for you either as a student. And sometimes it's the other way around, right? Sometimes your clinical instructor may not necessarily deliver the feedback in a way that is helpful to you, but it's how do you adapt and sort of adapt to that and kind of deal with it, right? So if that's having a professional, but like collaborative conversation about how the feedback could be different, etc. Yeah, that's, I think in more things. Yes. Well, good for you is that there's not that much swallowing. You can avoid swallowing altogether probably in the palate because a lot of it is speech. But there is also a lot of feeding and swallowing components with children. You know, I would say at least for cleft palate, I don't think that feeding and swallowing has to be a #1 skill set for you to work with patients. So for example, there's a clinician, a speech pathologist at Children's who's, you know, he speaks at the national level at American Cleft Palate Association. He speaks at conventions. He's been authors on different research papers and stuff like that. He's amazing at cleft palate, and he doesn't do anything with swallowing. So he works in the outpatient setting, and there's another person who does the feeding and swallowing part for different and most school-aged cleft palate children aren't working on feeding and swallowing. Usually it's the infants and very young children who are going through surgeries. So that's probably good news for you. On the inpatient side, for those of you who are interested, there's like a whole component of it, different adaptive types of bottles that are more flexible, techniques for feeding cleft palate to help pace them because they might have an open palate and things like that. But yeah, I would not say that's an absolute necessity. The other thing is, remember, stay open. So maybe you have a fear, but you'll overcome it when you do your externship. Maybe that might be something to work on to face your. Yes. Happy. Yeah.
You take volunteer.
That's a good question because I get this kind of question a lot. So we do not take observers. So the hospital and many hospitals have now started to change their policies due to like risk and legal things and confidentiality breaches and things like that. Where we used to take observers all the time, and it was beautiful and awesome, and we loved it, and the students loved it. But unfortunately, the policy has changed. So now our policy is that you can observe if you commit to being a hospital volunteer for a set number of hours, which is 100 hours. It's a lot, it's a big commitment. So that's the way you can get in and volunteer observe. What I would say is there are still other facilities that allow for observation and volunteering. But yes, so we take volunteers all the time. But in terms, I think a lot of people wonder about volunteering because they're really wanting to do shadowing or observing. So you can't really do at my facility observing or shadowing in the absence of volunteering. You have to be volunteer.
Like, if I were to commit 200 hours, would I be volunteering in terms of what the hospital wants to do, or can I choose like speech?
So it's 100 hours, and if you do, you would indicate in your application that you wanted to volunteer for the speech department, and then they would try their best to place you, and I wouldn't see why they couldn't place you. Yeah. And then, but also being a volunteer means you're not just sitting and observing therapy all day. You know, you're there to volunteer, so we might have you doing some photocopying or cleaning or things, and also incorporate some opportunities for shadowing. In other news, I would say on a side note, I think there's a lot of private practices, skilled nursing facilities, and other opportunities where they still allow for shadowing without volunteering. So I always tell people to just shoot for the stars, call people, you know, and just call departments, ask them, be polite, let them know you're CSUN, don't be demanding. Yes.
Kind of going off what she was asking, for volunteering, is there usually like a specific, like, they require a specific teacher or volunteering?
Not really. Usually you have to meet, you know, like to take your tetanus and TB shots, like health kind of vetting, and then like a certain level of background checking if it's a big hospital. And no, you don't have to. We have volunteers of all ages like at our hospital. And then of those, you know, some people want to volunteer for the physical therapy department, so they write that on the application. I think we even take high school students, so necessarily have there's a certain age limit, but qualify. Yes.
So say someone knows exactly that they want to work in a medical setting, or they'd like to broaden their horizon and see what it's like to work at a medical setting, and they do know that they want to work with peds, and since working as an SLP with peds in a medical setting is so hard to get into, what can you do as a student to kind of align yourself or set yourself up for success to kind of get those opportunities?
Great question.
Besides volunteering.
Right. Well, yeah, I would say if you know anyone that knows anyone, you know, then that's shadowing or observing would be great. What I would say too is, because I'm going to sort of bridge another concept here, okay? So a lot of people also ask me, if I start off working in the school district, will I ever be able to get hired in a medical setting? So a lot of people are like, do I hold out and get a CF in a medical setting, but it's so difficult, so competitive, and now I'm unemployed and I don't have money, like what do I do? But then I don't want to ruin my chances, right? What I would say is it's like similarly to being a student. Even if you didn't ever get observations directly in a pediatric medical setting, I think the important thing is that you have had opportunities to be around pediatrics, period, right? So for example, that person who's applying and who's a speech therapist in a school, depending on who they're competing against, if it's against somebody who's had, you know, many years of experience in the hospitals, I might not necessarily disregard this person. Because again, like Dr. Strickrusa says, if this person who's very experienced is not a team player and doesn't have a great personality, I don't care that they have 10 years of experience. I'd much rather take this person who is already a very well-versed, experienced speech pathologist in the school, but I know could learn and be open to, like, that's the easy part, right? You can teach a skill. You cannot teach the collaboration, the receptiveness, your personality, those types of attributes, which to me, oftentimes, at the end of the day, kind of outweigh. You could be really, really smart and have tons of experience, but if you're like not fun to be around and create conflict and you're not a team player, you don't, you know, really, like, that could be a nightmare, right? So sometimes in the past, we have hired a CF over a more experienced applicant because that person felt like, based on our very extensive interviewing, we're like, you know what, they're a better fit for the team because this person probably wouldn't be able to adapt well to our culture here or whatever, right? So I think in that same way, it's really hard for me to say exactly what else you could do, except, by the way, if you were to get placed in a pediatric setting, I would say that's probably the most important thing, is doing really well in your pediatric externship setting. Because I think that really goes a long way for being able to get a job there. I'll have to think more about that. I think that's a really tough question. And unfortunately, it's not as easy. I think having a good relationship with your clinical coordinator is very important, and your professors, because kind of need to also have, advocate for yourself, but know that there are limitations. But it doesn't hurt to also, ask your professors, ask your clinical supervisors, because there's so many clinic supervisors here that might have advice. Sorry, I know that's not that. I don't know.
I think, trying to find continuing education opportunities that would, be relevant to a hospital setting.
Definitely.
Also, there are public school settings are so varied that if you can find a job where you're working with, energy reentry, anything like that, that makes your public school experience stand out.
That's a great example, because I know that a lot of students go to ASHA or CASHA. And so, not that you have to, but that's a great opportunity where students are allowed to attend and take maybe pediatric sort of your courses, and you could write that on your application. Say, hey, I've tried to do this course. What's it shows me that you're trying to do more. That's great. Yeah.
Do they only really care about that if you're a grad student, or if you've been doing it undergrad and all the way up? Can you include what you've gone to?
Yeah, sure. Why not? I would. If you're trying to get into, if you're getting into pediatric, sure. Yeah, I would list it. Why not? Yeah.
I have a question regarding the interview. Since you're working with a lot of people, and I think when you interview people, do you think you could take like a view about the person depending on how he looks, how he wears, how he talks? Because sometimes people like their English is not the first language, and some of them think, oh, the accent.
Right.
It's not really professionally. You take that into consideration.
So yes and no, right? I really hope that a place that's interviewing is not going to be biased in that way, outrightly, right? Now, there's a whole thing right now going on about implicit bias, right? We all have some kind of implicit bias, but the idea is that for me, if I'm interviewing you, based on the way you talk, the way you look, your ethnicity, your gender, I will not hold that at all to this, to weigh into my decision. And I hope that other places are like that. Can I speak for everybody else? No. Having said that, I would say, talking about appearance, I will tell you, it is very important to dress professionally. So outside of the way you're looking like, okay, so like you have your head wrap, right? That's part of you. But outside of that, you can look professional. Like you can become and not have a head wrap, but look unprofessional. Like you'd be really surprised at how many students come that aren't really dressed professionally. So even when we had observers, I had one time a student who came with sunglasses on her head, right? That's very unprofessional. It's not a good look at all. Some people come in jeans. I would at least ask before you come, is it okay to wear jeans? And if not, don't wear jeans, right? Just wear some black pants or something. Just look professional. You don't have to come in a suit, but you'd be really surprised at how casual and unprofessional students will come and also behave. So another thing is you're so eager to learn, right? And you see something, and so you'd be very surprised the number of students who interrupt the session with their comments, okay? Now, if a kid asks you a question or adult asks you a question, don't be weird and you don't answer, right? That's okay. But I've had a student who corrected the therapist's Spanish in front of the radiologist. That was really awkward. I've had a student who was interjected to say, oh no, I think what she meant was this or whatever, right? So just being mindful, but then it's always unintentional. Like everyone has the best of intentions. So just being mindful and saving your questions till the end, or unless you're invited to join. So sometimes I might invite my student observer to join in on the game because it would be great to have an extra player or something. That's great, awesome, right? But if not, then wait till the end of the session to ask your questions. So I do think professionalism is important. I would also say that in an interview setting, like Dr. Strickler says, that's the opportunity for you to sell yourself in a way that is pleasant but not overbearing. Oh, I also do this. Oh, you're looking for a hardworking student. Did I tell you that I'm also really hardworking? I think it'd be a really great fit here because this is how I'm hardworking, right? That's probably a little bit too much, but but being able to let yourself shine through, because sometimes if you don't do that, that might be your opportunity to show your personality.
I think you have to remember that in every way you communicate with people at that hospital, you get an introduction. Your very first phone call, your email. I mean, I get a lot of mail from students who want to apply to grad school. And hey, Christine, I want to know, do you require the GRE or whatever, things like that. Well, I even have now on my email that everything is considered part of the application. So, you know, keep that in mind, that it's nice to be friendly, but you do need to be appropriate.
Very true.
Every single bit.
The other thing too, I would say, even down the road as a professional, you know, sometimes you build really close relationships with your coworkers, or you are really friendly with, let's say, a physician or whatever, and there's still a line, right, about being professional, because you can feel comfortable and relate to people and still be friendly, but whether it's another nurse or another whatever, like, you know, you kind of need to have established some kind of relationship, and also even then, there's really, like, you always want to maintain a level of professionalism. The other thing is that therapy world is very small, and so you would be surprised at how many people I've heard about through another friend who works at a whatever, who happens to work at that place for per diem. I'm like, how do you even know her, you know? And it's just, you know, I know a lot of people, like I know Sherry Bulgari because we worked together at Memorial. I know Rosie Casada. I know, you know, so-and-so from grad school who's now at UCLA. Like, you just, like, your network starts to build, and the therapy is really small. And the point is, your reputation will follow you. So just
So you were talking earlier before about how important it is to be a team player. Could you present a case or illustrate a time when you were on a multidisciplinary team and probably another professional wanted to focus on something else, but your focus was just as important and you guys disagreed, and kind of how you maybe collaborated?
yes. It's a good interview question. Yeah, okay, so I mean, I'm sure I'll think of more later, and I'll say that it was probably a better example. The one that comes to mind would probably be in a stroke situation. So we're a certified stroke center, lots of different providers. We would round on all the patients, so physician, nurse, physical therapist, occupational therapist, speech therapist, right? And in this case, this patient had a right-sided stroke and had a lot of cognitive types of deficits. So it's kind of that, it's a little bit more detailed that example I gave earlier. I really didn't feel that this patient was safe to go home, but in every other way, he was doing okay, right? He could walk with the walker with help. He was medically kind of okay. They were going to discharge him, but he could not remember past like 5 seconds new information. And then problem solving or reasoning wise, he couldn't reason that he wouldn't be able to walk, that he shouldn't walk by himself, right? So that was a very big concern for me because they were going to let him go home the next day. with someone who was a caregiver that couldn't provide 24 hours of care. And so that was very concerning for me. When I initially brought it up, the physician, the medical team were basically said, I don't really, they kind of minimized what my concerns were. Are you sure? You know, or like kind of question, are you sure? But why do you think that? And so how I dealt with that was to give more specific examples instead of just saying, hey, he's really moderately, like severely impaired with, you know, right hemisphere, like types of symptoms, right? And so that was my example. I talked to the family, and then I did, in that case, I told the physician, I asked to talk to the physician, I caught the physician later. And in this case, you have a neurologist too. And so we kind of discussed it. In the end, they still discharged him. So I didn't agree with that. But I did feel like they had at least done more to set him up with supervision at home. And they ended up doing a follow-up in terms of services. So at that point, part of it was me accepting that I would have to trust that he's going to get the follow-up services, right? And then I did enough that I could do to get a little bit more, you know, support for him. And that's how I handled that. I would also say that in a non-clinical setting, in our departments, we have so many teams, right? You need your own team. So sometimes it's about picking up your coworkers' patients to help them cover patients for them, because, you know, a patient showed up without an appointment or something, you were counting on that hour to do something, but that's also being a team player, right? It's, even though it seems like that person doesn't always help you, you're kind of jumping in. So that's a good non-clinical situation.
I have a follow-up question to that, please. So when they discharge them, is it who kind of decides, like, is it like everyone has to agree, or like majority, or is there like one person says based off of?
So typically, you know, it's the medical team that decides. So ultimately, the doctor is the one who's who's taking overall care of the patient. So it's definitely not a majority consensus, I would say. Sometimes they're discharge dependent things. Okay, so for example, physical therapy needs to clear to say they're safe enough to go home. So for sure, in that case, physical therapy is the one that decides, hey, they're not ready. The doctor, I hope, is going to listen to, because that's the whole purpose of the doctor call, right? So that's the answer to that. I would say if you have a good medical team, they're listening, you know, they're compromising. And so the compromise in that situation, I felt very supported, was the case manager made sure that there was home health services immediately available, even though they wouldn't have ordered it before. So, you know, that I felt better about that.
Follow-up question. I know in Human Hospital, each patient has a team 5 to 6 to 7, and each team has a primary doctor. And then, so let's say, for example, gastroenterologist and then like a speech therapy, physical therapy. And like the speech therapist said, okay, that's fine, you can go home. And then something bad happened. Did you ever have like a parent calling me or calling me, oh, yeah, I got a speech problem or something related to speech? Like they're blaming me.
Yeah.
Because I know sometimes it's hard to.
So speech is usually not never a discharge dependent, right? Because you can still go home safely even if you can't talk well, right? But if it's, I have an example that's like eating and swallowing. So maybe the recommendation was that they weren't ready to go home on that certain diet. They wanted to wait for this instrumental study, and the decision was made to do it as an outpatient. So we had to send them home and do it. And then something happened, and then like the patient came back the next day because they aspirated, right? And it was like that. You know, at the end of the day, as all professionals, you can only do what you can, and you document, and you don't throw other people under the bus. You don't say, well, I don't think he's safe, but the doctor is going to do it anyway. You don't write that, right? But the point is, you say that you've had these conversations, you've educated the family, you've done whatever you can. Okay, this is the decision. I'm going to respect the decision of the medical team and advocate for the things that I feel very strongly about. And if you have a great team, they're going to listen and at least do something to have more support. I would say that happens often, where it's not necessarily like the outcome exactly that you wanted. And guess what? Sometimes I'm wrong. So I felt really strongly about something. I'm like, oh, for sure, this patient, I'm going to see him for getting swallow, so he's going to aspirate on everything, and I'm just going to, and then like he didn't aspirate on anything. But, and I have to be okay with saying, oh, okay, we didn't see it here, but it's yes.
I have another question from a live streamer. She wants to know, do you use AAC or do AAC evals in your setting?
That's a great question. So it's a really difficult answer that I'll try to simplify. In the medical setting, in a hospital medical setting, AAC is difficult to do because there are a lot of requirements for the evaluation that are very in-depth. So most reimbursement methods require you to work with the vendor and do their report, which is really long, and then you have to do your own report for your own thing, and then you have to set up a time that works for both the vendor and the patient and you. So definitely there are medical settings that do AAC. At ours, we use AAC if they in different forms, right? So AAC can be low tech, high tech. It could be a whole plethora, right, of that scale. So we definitely have they're called like boogie boards. It's like an LED writing thing. We use iPads. We use Colloquo, which is like an app that's sort of like we use Boardmaker. In terms, if the patient themselves have an AAC, we might use it, but we don't actually get them with the official AAC device and try and set them up to do it as an outpatient. Yes. What are the bigger challenges? Honestly, I think, you know, it doesn't matter where you work. I think it's the people, right? Getting along with your team. There's just lots of different personalities, and some people don't communicate in the same way that you do, right? So adjusting and learning how to communicate with different team members. It could even be your direct coworker, right? I don't care where you work, but isn't that mostly where like conflict and miscommunication happens? So I'd probably say those have been some of my bigger challenges. And then for me, my biggest challenge personally was the place that I was at when I was first there, experienced a really high turnover because they restructured the department. And so I was left alone, for a period of time, not alone, but almost alone after my CF. And that was probably a very big challenge for me because it required me to be very resourceful and advocate and draw boundaries, what I didn't feel was okay. So it felt very tempting to be like, well, I'll just figure it out or I'll learn. But really knowing when to ask for help is very important. In fact, I would say that's one of the other big qualities in a student when you do your externship is the balance of being autonomous and having some independence. Like, I don't want to have to tell you every single step every single time, but at the same time, it's really, really important that I trust that you're going to know when to ask when you need help. Because if you're not feeling comfortable and you don't ask, that now is putting the patient at risk, right? But that's hard because sometimes you don't want to look stupid, you don't want to look incompetent. It's like, oh, just like figure it out. So I think that balance was hard for me, but at that time I didn't have a choice. So I became very resourceful. So I reached out to my friends at other sites. I took tons of classes, lots of CEUs. I think I gave that example. I talked to my manager, I don't feel comfortable seeing patients for voice until I've had more training. That's right. We should actually, refer them out to another place. And that. We came up with a training plan. So those are probably some of the challenges. The other challenge probably is, as a therapist, you feel very passionate and care a lot about your patients, and you still work at a job. And so there are rules and guidelines of your job that you have to follow. That and so that's part of any job. So, yes.
When you do therapy, do you use the same other questions?
Same question. So yes and no. I think yeah, definitely. I try to be fun even when I'm an adult, when I'm working with adults. I would say that the hierarchy of treatment of therapy, the principles of therapy are the same, right? Except that pediatrics are not just a miniature version of adults. So you can't just do everything you do for them, but in a small body, because they're developing at a different rate. Their anatomy looks different because of their growth is different, right? So there's definitely a whole different type of skill set to learn in terms of how to do pediatrics. So that's my short answer. The other thing that I would say is, as an adult therapist, I think most students, including myself, I had to learn this. We tend to talk to adults like children. So you don't realize that you're doing it. But all of a sudden, I'm like, hi, Mr. Smith, right? And so that's usually a very common theme feedback I'm giving to students is just talk like a normal person, right? Like you would to any adult, even though they may not understand you. So remember, communication is everything, including your tone of voice, your body language. And a lot of people will say with aphasia after they're able to talk, that they could sense that somebody was kind or something by the tone of their voice or condescending by the, because right, you could not understand a word I'm saying, but you kind of know, like persons feel like they're kind of talking bad about me, right? So anyway, communication. Yes.
Being in a manager position and straight away from working with patients.
Yes, and actually it's something, that's my challenge. That's been one of my challenges. That's been really difficult for me because I've always really enjoyed and really, really loved being a bedside clinician. For me, I was lucky because my road to being a manager included a middle step. So I was a clinical coordinator, and that required me to see patients half of the time and do administrative things half of the time. So that was a good transition. I will say there have been some times in the past few years where I really miss treating therapy, doing therapy and seeing patients. So, I think you have, and I have coworkers who have been doing therapy for longer than me and have no desire to go into management, right? So it's not for everybody. I would say that's been one of my internal struggles. I now kind of think of it more as if I can create a department that is strong and supportive so that the clinicians can do the work that they need to do, and maybe along the way I wish that I had management support as a therapist, right? So I would say I feel pretty connected to the therapist. I think recently though I was missing it a lot, so I might try to. I told one of my coworkers I think I'm gonna try to pick up a few patients in there. It's hard to balance, so I know our physical therapy manager also sees patients and incorporates a lot of mentoring through it. She has a specialty, so I think I might try to do that type of rep. It was very hard. And other people are like, I need a break. I'm good, I did home health for a while too. So that was kind of good because I got my therapy sort of fix, and I was able to do hands-on. And then it got to be a little bit much, so I phased out of that. Yes.
So when working with cleft palate, can you kind of tell us about a treatment technique or an evidence-based practice or a kind of concept that's kind of helped you overall treat cleft palate?
Yes, definitely. I think for cleft palate, the hardest thing for me has been eliminating compensatory misarticulations. So for example, if you have glottal stops where you're replacing consonants with a glottal production, right? So at my main mother, right? At my main mother, that's a glottal production, right? So I'm substituting as a glottal stop for all my consonants. That's very hard to treat and get somebody to eliminate. And so part of it in terms of evidence base is there's a whole literature of like evidence out there about like the hierarchy of eliminating sounds and things like that. So that is definitely something that I learned. So part of it is that if you're so used to, by the way, I was saying that's my baby brother, at my baby brother, right? That's a true life story, my little kid, Justin. And so part of it is, how do you get somebody just say, can't get that, you can doing it forever, is redirecting some of that. So starting with an H, for example, that's often one of the first steps, is just getting, and then you introduce lip closure. I'm trying to get to B, right? But you keep doing here. So I want to get away from back to productions. So that's one technique. Starting with an H, shaping it, getting your lip closure, doing it voiceless. If this is like the hierarchy, that might take, 3 months. But the point is, that's kind of what I'm doing. I have a plan in terms of how I'm trying to eliminate them. So that's one technique. Oh, yes.
But if your child has a how can you
Yes and no. That's your job to figure out. So there might be reasons why they can't structurally, they're just not able to. And so maybe they need to have a surgical intervention or repair, something like that. Sometimes they need to get a surgical repair, but it's going to be in 3 years or 2 years. So in the meanwhile, they still don't even have good or no lip closure. So you might work on oral placement of sounds, because guess what? The palate gets repaired. They're not going to talk like this if they don't they never learn how to close their lips. So surgery isn't magic, right? And a lot of people sometimes feel like, oh, we'll just wait for therapy until after they get the surgery. Well, meanwhile, now like 2 more years have gone by where they're not really shaping their sounds correctly. So that might be a reason why you might stay on. Other times it might be that they're doing lip closure, everything's fine, and it's literally just the hypernasality, and that might be a reason why you would not do therapy until. Like Ventura, Memorial, Children's. I think UCLA has some type of craniofacial team. Where was it? Loma Linda. Queen of the Valley has one. Fillers. So these are all like that. So I mean, if they will actually observe, that'd be awesome. Dr. TC, who I learned from, is amazing, and so she wrote a book. We got it off of hers, which is incredible. She wrote a book. I still use it. A lot of our therapists use that book for their therapy ideas. A lot of good resources on the American College Association website for families and not just for professionals. So that's kind of cool for them to learn something new. I feel like, are we talking about that?
You have less than 50 minutes.
Oh, okay. I was like, I felt like that was fine. I did want to say, do you guys have one question? I just wanted to say, if you ever have any questions, I really felt like one thing that was, that you don't always have access to are clinicians. Like, I didn't know a single speech therapist when I was going to grad school. And so the point is, if you ever wanted to get questions or something, you can always email me. If I can answer anything in any way or questions you might have, do that. The other thing is, I would say, I think just always be open to what your opportunities are here and now. So the point is, like, you might not get the best, like the exact placement you wanted, you might not, but the point is, again, you have opportunities to learn everywhere, and it's really what you do with that. It doesn't have to match up perfectly. So I would say, don't feel discouraged if your path doesn't look exactly the way you envisioned it to be. And yeah. Thanks for having me.
Yes, girls. Guys, 1, 2, 3. Take a photo. Yeah, so we can. I just need a couple of photos. Oh, they're like on track. Oh, right. Yeah. Right.